So the ELSA study, which I was part of, or the early surveillance for autoimmune diabetes, was aiming to develop and test an early detection program for type 1 diabetes for looking at islet cell antibodies. And so it was the first study in the UK really to understand or try and explore the feasibility of implementation and also the psychosocial effect of population screening in pediatric type 1 diabetes using a really simple dried blood spot screening test, a bit similar to the newborn screening test that's just posted back to the lab for analysis. So the results of the test, which were the results of the study that were published just last month, showed that our wraparound screening program, that's the dried blood spot, the confirmation of the test result, and then the education session to support families to understand results was really feasible. So everybody who had a positive screening test completed that pathway, including the education session, or almost everybody. There weren't very many adverse events, and these were mainly related to the blood tests, a bit like fainting. And we found that social media and schools were really effective at recruiting young people generally. But when we were thinking about underserved populations, so non-white ethnicity or those from more socio-economically disadvantaged backgrounds, actually the community clinics that we'd set up were much more effective. And then in terms of how acceptable the process was, almost 100%. So 98% of people who took part in the study found that the whole screening process was really acceptable with high satisfaction and trust in the study. And they found it really beneficial to take part at whatever the outcome. So yeah, it was a very successful study. We have recruited over 40,000 individuals to the study now in just over 3 years, which makes it the biggest screening study across the UK. And we've just expanded our research study. So we've just won some more money to go further with ELSA to look at things in a bit more detail to support general population screening. So the key takeaways are that screening using an NHS approved dried blood spot test is both feasible and highly acceptable to families, and there are limited and acceptable adverse events. We found that although home testing was preferred, when we recruited through our community clinics, that supported recruitment for those without a family history of type 1 diabetes and those from more disadvantaged populations or non-white populations. And we also found that actually screening facilitated a smoother transition. So when those children who were in early stage, asymptomatic, moved then into true insulin dependence in stage three, requiring insulin, that process was much smoother for them. So, type 1 diabetes is one of the most common chronic diseases in childhood, and there are about 1.5 million young people affected across the world. And it's caused by an autoimmune attack on the cells of your pancreas, which is a gland that sits just near your tummy, attacking the beta cells, which produce a hormone called insulin. And loss of those insulin producing beta cells cause high blood sugars. And up until recently, the only way to treat that was by using insulin via injection. It's got huge impacts on physical health, mental health, and quality of life. And that's not just for the young person affected, but also for their family. It's a relentless condition to live with. And we know from studies done over lots of different years that we can actually predict those children who will go on to develop type 1 diabetes needing insulin using those islet cell markers, islet autoantibody markers. And we know if you've got two or more of those markers, you're pretty much 100% going to need insulin at some point in your life. You'll develop insulin dependent diabetes. And the early detection has really big benefits. So we reduce the number of children presenting in metabolic emergency. So something called diabetic ketoacidosis, which has a high incidence of morbidity, so health effects, but also a small percentage of children do and die at diagnosis in diabetic ketoacidosis. But we also know that those children who are screened go on to have a much better glucose level longer term, over 5 years or more compared to an unscreened population. And more recently, we've got disease modifying therapies that are coming through both in clinical care and research pipelines. So if we identify these children in early stage, we can potentially offer them research trials or clinical therapy to modify or delay the progression onto insulin. That's a really good question. So what what we have at the moment is no general population screening program anywhere in the world apart from Italy. So Italy has mandated general population screening for children. But one of the things that the ELSA study found was that actually, if you have a family history, so a first degree relative, a parent or a sibling who lives with type 1 diabetes, that was a really good enabler into a screening and study entry. So almost 40% of ELSA participants had a first degree relative, whereas actually in the general population, most people don't have a family history when they're diagnosed with type 1. So about 85% of people with type 1 don't have a family history. And the individuals who did have a family history of type 1 in ELSA found the dried blood spot test more acceptable because it uses a finger pricker, very much like the finger pricker you use to test your sugars. They had a better understanding of the implications of a negative test and a positive test. And they were more likely to screen positive, so 10 times more likely than someone without a family history. So, potentially targeted screening within your type 1 clinic would be a reasonable approach. The only caveat I would say with that is you need to make sure your lab does multiple islet antibody testing. Many will just do one antibody without the others and then reflex test, so only test if that antibody is negative. And I mentioned that, ELSA 2, certainly in the UK, will be going on to understand the sort of health, economic, psychosocial benefits and implementation of delivering general population screening across the UK. So the only other thing that I wanted to sort of just mention was the fact that I've mentioned ELSA 2 already, but I think the other thing is that we will potentially be using genetic risk scores in the future to refine screening as well. So I think that that will be an important part of the screening program going forward, and also that there's a whole suite of other research studies looking at primary prevention using genetic risk score as the first marker, and then trying to prevent seroconversion to developing islet autoantibodies.